Hello everyone, I hope you all are doing great. I am Sabina, your mastermind faculty of Fundamental of Nursing and batch mentor of NORCET. So here we are presenting the simulation based nursing procedure videos. As we all know कि NORCET में the clinical part is increasing day by day. Now ज़्यादातर question जो है clinical procedure oriented होते हैं. So as a student we should be well oriented, well aware about how to perform a procedure and what will be the steps. So here you can get the glimpses of some of the important procedure in the simulation form of Fundamental of Nursing and Medical Surgical Nursing. If you want to watch all the nursing procedure of all the subject, then you can refer our NNL-VSL pack, which is available in Nursing Next Live application. You can subscribe to watch all the subject nursing procedure video.
In this video, a nurse will understand the various aspects of male catheter care, purposes, Corti bundle checklist, equipments required, steps of procedure, aftercare, and most importantly, what to do when things go wrong. In other words, common clinical error. Corti, catheter-associated urinary tract infection is one of the most common healthcare-associated infection. Hence, CDC has given a Corti bundle checklist to prevent Corti. Catheter care is one of the most important parameters to prevent the infection. It involves the cleaning of the urethral meatus, area surrounds the catheter insertion site and the perineum. Purposes: to prevent the Corti, that is a catheter-associated infection, to prevent from odor, and to provide a comfortable position and a comfort to the patient. Corti bundle checklist: hand hygiene or aseptic technique, assess the need for catheterization, catheter care given, catheter and urobag should be always connected and no king should be present. Urobag should be always below the bladder level. Equipments required: a tray containing kidney tray, underpad sheet, sterile watch piece, normal saline solution, pair of clean gloves, pair of sterile gloves, micropore, syringe, sterile tray. Let's see the steps of procedure of male catheter care. Enter the patient room. Perform hand hygiene. Introduce yourself to the patient and identify the patient.
Good morning, sir. Myself Rahul. I am a science staff nurse from 8 AM to 2 PM. Sir, may I know your full name, please? Okay, sir. Sir, I am going to check your ID band.
Check the non-drug order sheet and Corti bundle checklist. Explain the procedure to the patient.
Sir, as you are in the catheter, so doctor has advised to give a catheter care. So I am going to arrange the articles and coming within few minutes.
Arrange the articles. Provide privacy to the patient. Perform hand hygiene. Wear clean gloves. Place the patient in supine position and place the legs in abduct position. Remove the anchor tape to free catheter tubings and inspect the area for any kind of infection or inflammation. Remove old gloves. Perform hand hygiene. Assistant nurse will open the first flap of sterile tray and provide sterile gloves. Wear sterile gloves and open the another flaps. Assistant nurse will pour the sterile gauze piece in the sterile field and fill the bowl with normal saline. Take gauze pieces and make a mitten, dip it into normal saline solution, squeeze it and clean the area in circular motion from distal to proximal end by retracting the foreskin. Use single gauze piece for a single stroke. After cleaning with the normal saline solution, dry the area with the help of dry gauze piece. After cleaning, revert back the foreskin in the same position. With the help of another gauze piece, clean the catheter with single stroke in rotatory motion and in the same manner dry the catheter. Secure one end of the catheter with the help of micropore. Remove the old underpad sheet and spread the new one. Aftercare. Provide comfortable position to the patient. Discard the biomedical waste and replace the articles. Perform hand hygiene. Documentation. Common errors. Position is not given. Cleaning is not done in appropriate manner. Single stroke for single cleaning is not used. Foreskin is not retracted for proper cleaning. Key points to remember. 3 times catheter care is necessary to prevent patient from urinary tract infection. Always follow 𝐸𝐷 bundle while giving catheter care. Never forget to revert back the foreskin. Use normal saline solution for catheter care. Don't use oil-based cream or talcum powder around the catheter area. Always place the Euro bag below the gravity level for proper functioning. Drink plenty of fluids and regular exercise, but avoid anything too vigorous. Ensure your catheter is well supported before any exercise.
In this video, a nurse will understand the various aspects of female catheter care, steps of procedure, equipment required after care, and most importantly, what to do when things go wrong. In other words, common clinical error. 𝐸𝐷, catheter-associated urinary tract infection, is the most common healthcare-associated infection. Hence, CDC has given a 𝐸𝐷 bundle checklist which prevents 𝐸𝐷. Catheter care is the most important parameter to prevent the 𝐸𝐷. Purposes: to stimulate circulation, to clean the perineal skin, to remove body or germ, to prevent 𝐸𝐷. 𝐸𝐷 bundle checklist. Hand hygiene. Assess the need for catheterization. Catheter care given. Catheter and Euro bag should be always connected and no kink should be present. Euro bag should be always below the bladder level. Equipment required: a tray containing normal saline solution, clean gloves, sterile gloves, disposable underpad sheet, sterile couch piece, micropore, 20 ml syringe with 16 or 18 gauge needle, kidney tray, sterile tray. Let's see the steps of procedure of female catheter care. Enter the patient room. Introduce yourself to the patient. Check the patient's identification.
Good morning, ma'am. This is Shilpa, your assigned staff from 8 AM to 2 PM. Ma'am, may I know your name? Okay. Ma'am, can I check your ID band? Just give me a moment.
Check the 𝐸𝐷 bundle checklist and explain the procedure to the patient.
Ma'am, as it is a time for your catheter care, now I'm going to provide you a catheter care. Please cooperate with me.
Arrange the articles.
Just give me a moment. I will arrange my articles and I will be back.
Provide privacy. Hand rub and wear clean gloves. Provide dorsal recommend position to the patient. Inspect the perineum for arrhythmia, drainage, odor. Provide perineal hygiene if required. Remove the secured tail. Remove gloves and do hand rub. Assistant nurse will remove the first flap of sterile tray and put sterile gloves. Assigned nurse will open other flap and fill normal saline in bowl. Retract labia majora and clean the varus labia minora, vice versa, and center from clitoris to rectal area with normal solution. Use separate gauge piece for each stroke. Same way, pat dry. hold the catheter with non-dominant hand and with dominant hand clean with normal saline from inner to outer in rotatory motion. In the same way, pat dry. Secure the catheter. Change the underpad sheet. Aftercare. Assist patient in comfortable position and with top sheet. Discard the waste according to BMW policy and replace the articles. Hand washing. Document on the Corti bundle checklist with your signature and report any findings to senior staff.
Okay, ma'am, so I'm done with your catheter care. You can take rest.
Common errors. Use spirit solution instead normal saline solution during procedure. Gauge piece not changed after single stroke. catheter is not cleaned. Key points to remember. Communicate with unconscious patient as subconscious mind is awake. Use single gauge piece for each stroke. Solution to be used for catheter care can vary according to organization. Follow standard precaution. Maintain patient's privacy. In this video, a nurse will understand the various aspects of nasogastric tube feeding, steps of procedure, equipment required, after care, and most importantly, what to do when things go wrong. In other words, common clinical errors. Let's understand the concept of a nasogastric tube feeding. In this procedure, a nurse will administer the feeding directly into the stomach through the nose, which provides adequate nourishment to the patient who cannot feed himself or herself. There are two types of nasogastric tube feeding. First, intermittent feeding is the feeding that a nurse provides at the adequate time interval but not in a continuous flow. This type of feeding is given by a 50 cc syringe. Second, continuous feeding is the feeding that a nurse gives at a continuous flow by setting the infused feed with a drip rate. This type of feeding is given by a gravity bag. Purposes of a nasogastric tube feeding: to provide nourishment to the patient who cannot feed through mouth. Example, surgery in oral cavity or unconscious state. Second, to administer medications. Indications of nasogastric tube feeding: unconscious patient, oral surgery, spinal surgery, abdominal distension, poor oral intake, recurrent occurrence of aspiration, increased metabolic needs, coma, head and neck injury, obstruction of esophagus, positioning of the patient while giving the nasogastric tube feeding. Unconscious patient will be in semi-fowler position to prevent aspiration, whereas a conscious patient will be in a high fowler position. Among these two types of nasogastric tube feeding, firstly we will demonstrate the intermittent NG tube feeding. Steps of procedure. Check the non-drug order sheet and diet chart. Enter the patient room. Introduce yourself to the patient. Check the patient identification.
Hello, good morning ma'am. My name is Priya. I'm your assigned staff nurse from 8 am to 2 pm. May I check your wristband? Okay.
Always follow 5 movements of hand hygiene. Explain the procedure to the patient. Even if the patient is unconscious, explain the procedure to the patient as the subconscious mind of patient is awake.
Okay ma'am, thank you. Ma'am, according to the doctor's order, I need to provide you the NG tube feeding. So I will prepare my articles and will come back within few minutes.
Check the vital parameters. Arrange the articles. A tray containing clean gloves, towel, 50 cc syringe. Gauge pieces. 10 cc syringe. Plain water. Stethoscope. Kidney tray. Feet of the patient. Provide semi-fowler or fowler position as per the condition of the patient. Perform hand hygiene and wear clean gloves. Spread the towel. Check the NG tube placement by these three methods. First, inspection. Check whether the tube is not displaced by checking the measurement calibrated on the NG tube, which should be ideally between 50 to 60 cm. If it is less than this measurement, you have to immediately consult the doctor. Second, auscultation. Check the whooshing sound with the help of a stethoscope and a 10 ml syringe by flushing 10 ml of air into the stomach, along with the diaphragm of stethoscope placed at the left hypochondral region of the stomach. Third, aspiration. Check the aspirated content. If it is more than 30 ml, then hold the feeding and inform the doctor. Check the color and amount of aspirated content. Discard it and later record it into the intake-output chart. Prepare the feed according to the diet chart. Checking the feed's temperature is necessary. Kink the NG tube and attach the 50 cc syringe. Kink the tube and free flush the NG tube by water in an appropriate amount sufficient for clearing the tube. After clearing, leave almost 3 to 5 ml of water in the syringe and then kink it and start pouring the feed in the syringe. After feeding, post-flush the tube with appropriate amount of water. During the post-flush, leave almost 3 to 5 ml of water and kink it. Remove the remaining water in a kidney tray. Remove the syringe and close the cap of the NG tube. Remove the towel. Now, we will see the demonstration of continuous nasogastric tube feeding. The purpose, indication, initial steps of procedure will remain same. Instead of using 50 cc syringe, gravity bag will be used to feed the patient. Fill the gravity bag with appropriate amount of water required to clean the bag. Fill the gravity bag with water for pre-flushing the nasogastric tube. Make sure that the air bubble should not be there in the tubing. Kink the nasogastric tube and connect the gravity bag to it. Pre-flush the nasogastric tube and leave around 5 ml of water in the gravity bag. Check the temperature and consistency of feeds and pour the recommended amount of feeds in the bag. Set the bag with the estimated drip rate of the feed as per the doctor's order. Amount of fluid into drop factor upon time in minutes. Drop factor of gravity bag is 20 drops per ml. After that, you need to come almost 5 minutes prior to the feed finish. In between, keep observing your patient and gravity bag. Leave almost 5 ml of the feed in the bag for post-flush. Pour appropriate amount of water in the bag to post-flush, both the empty tube as well as gravity bag tube. Post-flush the ND tube. Kink it, detach and close the cap. Aftercare. First, ask the patient to remain in same position for 30 to 45 minutes to prevent regurgitation.
Okay ma'am, your feed has been completed. You have to remain in the same position for 30 to 45 minutes.
Second, discard the waste as per biomedical waste management protocols and replace the articles. Third, document it in the intake and output chart. Common errors. First, positioning is not given, which can lead to aspiration. Second, placement of the tube is not checked. Third, kinking of tubes is not done, which can result in entering of air bubble in the tube, which can lead to abnormal distension. Key points to remember. First, provide semi-forward position for unconscious patient and half-forward position to conscious patient, unless it is contraindicated. Second, consult the doctor to recommend a total pre-water requirement per day. This avoids potential of fluid overload. Third, make sure that there will be no air bubble inside the tubing. Fourth, once the feed has prepared, it should not be kept for more than 4 hours. Fifth, provide resting period in between the continuous feed as advised. Sixth, after resting period, check placement of tube before starting next feed. 7. Discard the feeding bag and 50 ml syringe after 24 hours. 8. For giving medication through a NG tube, we need to crush the tablet or medication with a pill crusher and dissolve it in a small amount of water and give it to the patient.
In this video, a nurse will understand the various aspects of oxygen devices, method of administration of oxygenation, its uses, indication and contraindication. Air, water and food are the essential component of life. Oxygen is a major component of air. Some patients with breathing difficulty cannot get enough amount of oxygenation, so they require additional amount of oxygenation either in the form of oxygen cylinder or central supply. They can be administered as a part of medical intervention. Oxygen is a colorless, odorless, tasteless and combustible gas. Oxygen therapy is the administration of oxygenation via oxygen cylinder or central supply. So next we'll discuss about the indications of oxygen therapy. There are various indications of oxygen therapy. Some of them are as follows. That is, when the patient is having a labored breathing, high altitude, patient under anesthesia, patient with critically ill condition, and patient who is having a decreased respiratory capacity. There are certain contraindications of oxygen therapy. It is contraindicated in the patient who is having a oxygen toxicity and patient with atelectasis. Oxygen therapy should be used with caution in patient with COPD, that is chronic obstructive pulmonary disease, because it may induce hypoventilation. In this video, we are going to demonstrate you about the two types of oxygen devices. First is about the low flow oxygen devices and second is about the high flow oxygen devices. So first, we'll discuss about the low flow oxygen devices. There are two low flow oxygen devices we are commonly using in hospital setting. First is about the nasal prongs or nasal cannula and second is about the simple face mask. So first, we'll discuss about the nasal cannula or nasal prong. Nasal cannula or nasal prong is the easiest and the simplest way of delivering oxygen devices to the patient who is having a respiratory difficulty. So in this mask, you will see there is a long tube and a plastic tube, and the end of the tube is diverted into the two prongs, and these two prongs we are going to introduce into the patient nostril. So like this, you can introduce these two prongs into the patient nostrils. And the other end of this port we are going to introduce into the oxygen. With the help of this oxygen device, we can deliver 2 to 4 liters of oxygenation. That means that is 24 to 44% of oxygenation. And this device comes under the low flow oxygen devices. And this device is widely indicated for the patient who is having a mild respiratory difficulty. And it is contraindicated for those patients who are not able to keep the mask in a place, and patient who is having a facial injuries and patient who is having a nasal blockage. This is all about the nasal cannula or nasal prong. So next we'll discuss about the simple face mask. So this is a simple face mask, and this simple face mask is basically a disposable plastic mask. This mask we are going to attach in the patient nostril as well as in the patient mouth area. So like this, we can attach this mask over the patient nostrils part, that is in the nasal part as well as in the mouth area. So with the help of these ports, the patient is able to expel out the carbon dioxide. And this end portion we are going to attach with the oxygen cylinder. Either you can attach this port with the help of the oxygen cylinder or with the help of the central supply. And this simple face mask comes under the low flow oxygen devices. And with the help of this simple face mask, we can deliver 4 to 8 liters of oxygenation. That means we can deliver 45 to 60% of oxygenation. And this mask is widely indicated for the patient who is having a chest pain, dizziness and minor hemorrhages, and it is contraindicated for those patients who are not able to keep the mask in place, and patient who is having a psychological effect of mask therapy, and patient who is having a facial injury. In the continuation of this video, we are going to demonstrate you about the high flow oxygen devices. There are various high flow oxygen devices such as Venturi mask, non-rebreather mask and hydrotrack. So next we are going to show you about the high flow oxygen devices. There are many high flow oxygen devices we are using in the hospital setting. So we'll learn one by one these high flow oxygen devices. So first we are going to discuss about the Venturi mask. This is known as the Venturi mask, and this portion is known as the ventures. And this ventures we are going to connect with the end portion of the Venturi mask. And the mask we are going to attach with the nasal and the oral cavity. Means we have to cover the nose and the oral cavity of the patient with the help of this mask. This mask is basically a medical device, and this is widely used for the patient who are on the controlled oxygen concentration. And in this mask we are going to attach the tubing. The one end of the tubing we are going to attach with the ventures, and the other end of the tubing we are going to attach with the oxygen cylinder. and with the help of this we can deliver the exact amount of oxygenation to the patient. And this mask comes under the high flow oxygen devices, and it is widely used for the patient who are on the controlled oxygenation, and it is contraindicated for those patients who is having a decreased respiratory effort, apnea and severe hypoxia. So this is all about the Venturi mask. So next we are going to show you about the non-rebreather mask. In non-rebreather mask, the main difference is in this you are able to see the reservoir. This reservoir we are going to fill with the oxygen, and you are going to see the flap. This flap is widely used when the person is able to inhale the air. This flap will remain open, and when the person will exhale the air, this flap will remain closed. The main mechanism behind the opening and closing is when the person is inhaling the air, the flap will remain open and the person will inhale the exact amount of oxygenation, that means the 100% of oxygenation. And when the person will exhale out the air, that means this flap will remain closed and the carbon dioxide will release from these pores. So in this there is no any significant chance of mixing of air. So now I will show you how you can attach this mask over the patient area. This mask area we are going to cover the nasal and the oral cavity of the patient. So like this you can attach the mask over the patient face, and the one end of the tubing of oxygen we are going to connect with the mask area, and the end area we are going to connect with the oxygen cylinder, and this is how we can deliver the exact amount of oxygenation to the patient. And this mask comes under the high flow oxygen devices, and with the help of this mask we can deliver that is 8 to 15 liter of oxygenation, that means more than 90% of oxygenation. Why we are delivering 90%? Because in this there is no any mixing of air, because there is a presence of flap over the mask area. And this mask is widely used for the patient who is having a carbon monoxide poisoning, patient with physical trauma, and patient who is having a cluster headache. And it is widely contraindicated for those patients who is having a CO2 retention, patient with facial injuries, and patient who are not able to keep the mask in place, and patient who is having a psychological effect of mask therapy. So this is all about the non-rebreather mask. So next I am going to show you about the partial rebreather mask. So this mask is known as the partial rebreather mask. This mask is similar to that of the non-rebreather mask, but the main difference between this partial mask is in this you are not able to see the flap. So because there is no any presence of flap, so there is a mixing of air. Now I will show you how you can attach this mask over the patient body. So first, this mask will cover the nasal as well as the oral cavity of the patient. And in this you will find the reservoir. This reservoir we are going to fill with the oxygen, and the end of this port we are going to connect with the mask, and the last port we are going to connect with the oxygen cylinder. So this is how we can deliver the exact amount of oxygenation to the patient who is having a respiratory difficulty. As this mask comes under the high flow oxygen devices, and with the help of this mask we can deliver that is 8 to 12 liter of oxygenation, that means less than 60% of oxygenation. The reason is why we are not delivering more than 90%, because in this there is no any presence of flap. So because there is no any presence of flap, so there is a mixing of air, that means oxygen and carbon dioxide. And the indication of this mask is, this mask we are widely using for the patient who is having a carbon monoxide poisoning, cluster headache, and patient who is having a physical trauma. So this is all about the partial rebreather mask. So next we are going to show you about the HydroTrack. HydroTrack is also a high flow oxygen device, and this is also known as TPs. And this mask we are going to use for the patient who is on the tracheostomy. In this you will see this hollow part we are going to attach with the tracheostomy. This port we are going to connect with the oxygen tubing. In this you will see the flap, and in this flap you are able to see the hole. With the help of this hole we can do the suctioning part. So now I will show you how we can attach this portion we are going to attach with the tracheostomy, and the one end of the oxygen tubing we are going to connect with the hydro track, and the other end we are going to connect with the oxygen cylinder, and we can deliver the high concentration of oxygenation with the help of this mask. And if you want to perform the suction, for example, this patient is having an excess amount of secretion, so we can open this port and we can perform the suction over this area. So this mask is having a multiple function, so we can deliver the high concentration of oxygenation with the help of this mask. So this is all about the hydro track and high flow oxygen devices. Key points to remember: check the identification of patient, check the diagnosis and need of oxygen therapy, check the doctor's order for initiation of therapy and dosage, assess the patient for any sign of anoxia, assess the patient's vital sign and breathing pattern carefully before starting the therapy, explain the need of oxygen therapy and the sequence of the procedure, gain the patient's confidence, keep the patient in a propped up position or Fowler's position. In this video, a nurse will understand the various aspects of IV cannulation, its indication, steps of procedure, article required, aftercare, and most importantly, what to do when things go wrong. In other words, the common clinical errors. Intravenous cannulation is a process by which a small plastic catheter is introduced into the peripheral veins. Intravenous cannulation is an invasive procedure where we are puncturing the veins for the administration of a fluid, medication, etc. The main aim of the intravenous management is safe and effective delivery of medication or the treatment without any discomfort or the pain. So next we'll discuss about the indications of the intravenous management. The main indications are, that is for the blood sampling, administration of the blood products, administration of the fluids, administration of the total parenteral nutrition, and the administration of the medication. So now with the help of the procedure demonstration, we are going to teach you how to insert the IV cannula. Enter the patient room. Perform hand rub. Introduce yourself to the patient.
Good morning, ma'am. I am Shilpa, your assigned staff from 8 AM to 2 PM. Ma'am, may I know your name?
Check the patient identification.
Okay, Miss Aarti, can I check your ID band? Thank you.
And explain the procedure to patient.
Ma'am, as your doctor has prescribed some of the IV medications for you, so for that there is a need of putting an IV cannula. Kindly cooperate during the procedure.
A tray containing sharp bin, saline flush, 70% isopropyl alcohol swab, tegaderm, tourniquet, IV cannula of different sizes, 26 purple, 24 yellow, 22 blue, 20 pink, 18 green, 16 grey, 14 orange. Sterile gauze pieces, non-sterile gloves, drape sheet, kidney tray. Position the patient appropriately. And identify the non-dominant hand. Check for any contraindication, example, infection, damaged tissue and AV fistula. Perform hand wash. Wear clean gloves. And put the drape sheet.
Ma'am, can you please lift your hand? Thank you.
Identify the vein. Apply tourniquet. Clean the site over the vein with alcohol swab in circular motion from center to periphery and allow to dry. Remove the cannula from the packaging and check all parts are operational. Hold the cannula in dominant hand, stretch the skin over the vein to anchor the vein with your non-dominant hand. Insert the needle at an angle of 25 to 30 degree to the skin. Observe for blood in the flashback chamber. Release the tourniquet and gently advance the cannula over the needle, withdrawing the guide. Apply gentle pressure over the vein and remove the white cap from the needle. Flush the cannula with 2 to 5 ml of 0.9% sodium chloride. Attach the white lock cap. And secure the cannula with an appropriate dressing. Aftercare. Discard the waste according to biomedical waste policy. Hand wash. Document the procedure in nurse's note, which includes date and review date, any problem encounter, and site and size of cannula and time.
Okay ma'am, so I am done with your cannulation. You can take rest now.
Common errors. Tourniquet is not applied. Area is not cleaned with alcohol swab. Angle of insertion of cannula is not appropriate. Key points to remember. Avoid puncturing the vein in close proximity to an infected wound. Make use of the most distal part of the vein. Try avoid puncturing the vein of lower extremities in adult because of the high risk of development of deep vein thrombosis. Avoid puncturing the vein on extremity having a shunt.
In this video, a nurse will understand the various aspects of incentive spirometry, steps of procedure, equipment required, aftercare, and most importantly, what to do when things go wrong. In other words, common clinical errors. Incentive spirometry is also referred as sustained maximal inspiration. Incentive spirometry is designed to mimic natural yawning by encouraging a patient to take a deep, long, slow breaths. Purposes of incentive spirometry: to increase transpulmonary pressure and inspiratory volume. When the procedure is done on a regular basis, airway patency may be maintained and lungs atelectasis can be prevented and reversed. Indication of incentive spirometry: thoracic surgery, lower abdominal surgery, patient with neuromuscular disease, patient with spinal cord injury, presence of thoracic binder, prolonged bed rest, surgery in patient with COPD, patient in expiratory capacity less than 2.5 liter. Articles required: a tray containing incentive spirometry, steps of procedure, identify the patient.
Good morning, sir. Myself Rahul. I am a science staff nurse from 8 a.m. to 2 p.m. Sir, may I know your full name, please?
Mr. Nayak.
Okay, sir.
Check the non-drug order sheet. Explain the procedure to patient.
Sir, doctor has advised me to give a incentive spirometer. The main purpose of giving this therapy is it will strengthen your respiratory muscle.
Perform hand hygiene. Provide relaxed and comfortable position to the patient. Example, sitting upright in a chair or side lying if extra volume is required in one lung due to ventilation perfused matching. Give incentive spirometry to patient. The patient is instructed to hold the spirometer in an upright position, exhale normally, and then place the lips tightly around the mouthpiece.
Sir, you have to hold the spirometer in an upright position, and now you have to place your lips tightly and you have to inhale slowly to raise the ball.
The next step is a slow inhalation to raise the ball, flow oriented or the volume oriented in the chamber to the set target. At maximum inhalation followed by the breathe, hold and normal exhalation. Aftercare. Wash hands. Record procedure in nurse's note. Key points to remember. The technique is inappropriate as the sole treatment for major lung collapse or constipation. Hyperventilation may result from improper technique. Discomfort may occur secondary to uncontrolled pain. Development of bronchospasm may occur in susceptible patients. Close monitoring of patient with hyperreactive airway should be maintained. Advise patient to take approximately 10 incentive spirometry breaths per waking hour. Use clinical reasoning to prescribe using frequency, intensity, time, and type principles. Patients with an oxygen requirement can use the device with a nasal cannula or a device which entrains oxygen. Deep breathing offers a similar effect. However, using an incentive device as feedback may create greater inhaled volumes, greater control of flow, and more motivation to participate in therapy.